new procedures in INR. Mostafa Farid هيعمل presentation إن شاء الله 15 دقيقة إن شاء الله. Good morning everybody, and this is a very non-typical talk about the new things we have in interventional neuroradiology. We don't have it yet, but it is soon to come. Okay, one of the things that is really frustrating for everybody is to deliver medications to the brain or stem cells, because we have this thing called the blood-brain barrier. The blood-brain barrier, without the blood-brain barrier, we could easily have a brain toxicity and brain poisoning. So this is our blood-brain barrier. It is composed of many walls to prevent the toxins, but the most important part of the blood-brain barrier, can I have a pointer if there is a pointer? The most important part of the blood-brain barrier is the tight junction between the endothelial cells. Yes, thank you. Yes, the tight junctions. This is the most important part of the blood-brain barrier. So, how can we overcome this blood-brain barrier in order to deliver drugs? Imagine we are placing our catheter inside the internal carotid artery and middle cerebral artery, and we want to deliver a drug to cure a disease. We can do this by focused ultrasound after injecting microbubbles. Microbubbles, they are safe. If you go online and treat, they are safe. They do not cause ischemia. And when you generate an ultrasound wave to the target area, these microbubbles go crazy. They jump everywhere. And when they jump everywhere, they are like the, the music bars we see in music applications. This is what happens to the microbubbles. And they start kicking away the endothelial cells. Like this. They start to create like holes and spaces for this in endothelial cells so we can deliver our drugs. Studies performed on this said that this lasts for 4 hours. So in this 4-hour period, we can deliver our drugs. This is what the focused ultrasound machine looks like. This is an MRI, and you attached the ultrasound transducer corresponding to the target area. You want to deliver the ultrasound waves, and it is a low intensity focused ultrasound. It is a LiFo. We all know the HIFO. This is the high intensity ultrasound that we used for ablation and coagulation of many diseases, but this is rather a low intensity ultrasound wave that causes transient mechanical disruptions of the blood-brain barrier so we can deliver our drugs. But this was not the first method people thought about to disrupt the blood-brain barrier. In previous times, people used to inject intra-arterial mannitol, and you know mannitol has a very high osmotic effect, so it sucked the water out of the endothelial cells and it made them shrink, and the gaps between the cells became wider and drugs were delivered. But this was for a very, very, very transient time, maybe minutes. You had minutes of breakage of blood-brain barrier, and it was not very efficient. Studies in respectful journals like Nature and New England Journal of Medicine started talking about this technique in treatment of Parkinson's disease and treatment of Alzheimer, delivering drugs in Alzheimer that can capture the amyloid proteins that cause the disease, or in Parkinson's disease for better delivery of the drugs. And also studies now are used to treat glioblastoma multiformes. If you don't know what glioblastoma multiforme it is a very high grade brain tumor, and there is no success in treatment of this disease. We fail to treat this disease. Why do we fail to treat this disease? Because it is an infiltrative lesion. The surgeon cannot remove half of the brain. It is very difficult. And you do not know where the exact margin and where the cells are seeding in the brain tissue. Another thing, there is a quite good blood-brain barrier. Of course, in the center, the blood-brain barrier is disrupted due to the new blood vessels that are not working well, but the rest of the tumor has a well-established blood-brain barrier. It is like throwing a pile of rice on the floor and trying to collect it. This is the treatment of GBM. So you cannot treat it by surgery, and you fail to give chemotherapy due to the blood-brain barrier. I think if we are able to disrupt the blood-brain barrier, we will see good advances in treating this disease. The second new thing in interventional neuroradiology, migraines. Everybody has migraines. It is a very, very bad headache. I don't know what the incidence of or prevalence of migraines is, but I think everybody has migraines. And most people, these migraines could be aborted by drugs, but a considerable percentage of people who have this condition called status migrainous, they are having very, very bad quality of life. So, in order to understand migraines, there has been many, many theories. But one theory, I think it is very accepted, it is the trigeminal-vascular pathway. We all had migraines, and we all felt the throbbing nature of the headache, so it has to do something with blood vessels. So it is a puzzle. So if we have a puzzle, if we play the game of the puzzle, in order to succeed, we need a starting point to place our puzzle. The starting point is believed to be the trigeminal ganglion. The trigeminal ganglion is hyperexcited. It goes crazy. And we know that the direction of the trigeminal nerve is from the face, sensory, is from the face to the trigeminal nucleus in the brainstem, and to the thalamus and to the brain. But something else happens in migraine. The nerve endings of the trigeminal nerve around the blood vessels in the dura, they start secreting peptides, proteins. These peptides, they cause inflammation of the dura. It is called a neurogenic etiology of dural inflammation. And these peptides also causes mast cell degranulation. And this mast cell degranulation causes severe vasodilatation. This is a very, very important slide, and it took me a lot of time to understand these stuff. I am a radiologist, I'm not a neurologist. And it took me a lot of time to summarize it. So let's just read it. The pathway of migraine starts in the very sensitive trigeminal nerve ganglion, activated by certain triggers. What are these triggers? Lack of sleep, lack of coffee. You know these triggers. These triggers, somehow, they activate the trigeminal ganglion, maybe through the hypothalamus, maybe through the limbic system, we are not very sure, but it starts in the trigeminal ganglion. And downstream, peptides are released from the perivascular nerve endings in the dura, which causes neurogenic inflammation and mast cell degranulation. And upstream, the pain is transmitted to the thalamus and to the cortex, and maybe even to other structures like the hypothalamus and limbic system. That's why in migraine, we can have some prodromal symptoms like very labile emotions, tendency to vomit, all these stuff. And this is a detailed image of actually what happens, and the lots and the numerous connections we see between the trigeminal nerve and the trigeminal ganglion with structures like the hypothalamus and the thalamus and the sensory cortex. So what is the role of interventional neuroradiology? Well, it's very simple. We go into the middle meningeal artery and inject lidocaine. And this has proved its efficacy in a number of pilot studies. And I think these studies are designed very well. All we do is inject 50 milligrams of lidocaine, and this blocks the trigeminal vascular pathway cycle, this vicious cycle of pain. This was discovered when we started treating subdural hematomas by embolization. This study in the Neurointerventional journal, very respectful journal, it said that the people that were treated with embolization for subdural hemorrhage, they had no more headaches. And this steered these studies in interventional neuroradiology to study the intra-arterial effect of lidocaine, and this is another study in another journal, and the studies were very successful. Okay, we all know that lidocaine has a very short life, but it is not, the pathway of mechanism for lidocaine is not to anesthetize and to inhibit the pain, but rather to interrupt the vicious cycle of the trigeminal vascular pathway of central sensitization. Third new thing in interventional neuroradiology is MEVOs, distal middle vascular occlusions. Like we all know, we treat the major occlusions like the internal carotid artery or the middle cerebral artery, M1 segment. What about the distal M2 segment? What about the M3 segment? What about the M4 segment? Is there a window for this? Yes, there is, because we can. We can get these clots out. Why shouldn't we get them out? What typical scenario do we see these cases in? I've met these, I'm sure Dr. Wissam and me, we have encountered these cases in our practice. There is a typical case of stroke in the internal carotid artery or middle cerebral artery, and after the thrombectomy, we do our angiography and we find a little fragment of embolus occluding the anterior cerebral artery. So what do? We chase it because we can. We deliver our catheter, and the thing we do different is that we adjust the length of the catheter so it fits the tiny embolus. And of course, we pull very slowly in order not to cause hemorrhage and to cause disasters. Okay? There has not been big randomized control studies discussing MEVOs, but there are lots of good observational studies, and this study in particular in the Journal of Neurointerventional Surgery, it is a meta-analysis that collects all these observational studies, and it proves positive outcomes for these cases. Thank you very much.
Many thanks, Dr. Mostafa, for this very impressive presentation about the new advancement and the new techniques. Actually, I have two comments for this new techniques. The first one about the disruption of the blood-brain barrier. There was previously many trials to deliver intra-arterial drugs, especially in glioblastoma. But unfortunately, till now, still we have, for example, the Avastin. This drug has many side effects for these patients, persistent vomiting, intolerable headache. So we have still two problems. We have the disruption of the blood-brain barrier, and we have, on the other hand, the delivery of appropriate drugs to the brain. The other comment about the new techniques, as you mentioned also, the last international conference we have been there, they invented another stent to be delivered in the superior sagittal sinus in paralyzed patient to control the influence of the brain over the extremities of this patient. And I think it is very simple to deliver in the superior sagittal sinus, and it has receptors inside like the pacemaker, and I think it will be a revolution in medicine for this kind of patients. Many thanks, Dr. Mostafa, and if any questions for Dr. Mostafa. So many thanks, Dr. Mostafa. And we will now move